Hey guys, can folks hear me?
Yep.
Yep.
Excellent. All right, let's get started. Okay, so yeah, let's get started. We'll have some people probably sign on, midway through and such. But we're going to talk about degenerative cervical pathology this afternoon. We had a recent OIT test that I was informed had a bunch of cervical and bunch of lumbar questions, and so I'll address some of those through this talk. We'll also talk about some sort of real life examples of cases that we're thinking about, like who to operate on, when to operate, and in what type of operation. And we have a whole separate talk for cervical myelopathy a little bit later this series, so I won't go into a lot of detail, but any talk that dealt with degenerative cervical pathology and didn't mention myelopathy certainly would be incomplete. So we'll gloss over that a bit as well. So, okay, cervical spine, a couple of conditions we need to be concerned about: radiculopathy versus myelopathy. Surgical indications, for the most part, are going to be pretty clear cut for all surgeons that you guys are working with. There's some subtle nuances that may come about when you work with the three of us, but in general, what I will be saying will be true for pretty much all the surgeons in our group. Okay, so when somebody presents to clinic, we want to know the difference between somebody who has neck pain versus arm pain, and then somebody who has pain in the neck with coordination problems. Those are three separate entities. They're treated in different ways. They have different prognoses, and the whole conversation in regards to their condition changes. So pain in the neck can be from any number of things: the muscles around the neck and the intervertebral disc, the set joint. Whereas pain in the arm really leads down a pinched nerve type of phenomenon. And those who have a pinched nerve tend to certainly be more acute, and certainly can be more debilitating, that may lead down a path of surgical treatment. The coordination problems patient needs to be teased out by a spine surgeon or a spine physician, typically, because these are the questions that we ask that a lot of practitioners do not ask, and they're not that noticeable in symptoms. So, but if they exist, really changes the course of the type of care that we would offer somebody. So radiculopathy, as we all know, is pain down the arm in a dermatomal distribution from C4 distal. It implies that there's a nerve root impingement issue, and is typically a focal problem. So 1, 2 levels, occasionally 3 levels, if the patient's really unlucky. The affected nerve root is different from the lumbar spine. So the lumbar nerve root, I'm sorry, it's different from the lumbar spine in some respects. In both the cervical and lumbar disc, the lower root is typically affected. L4-5 discs gets the L5 nerve root, and the C5-6 disc gets the C6 nerve root. But what is different is that a far lateral lumbar disc herniation gets the exiting nerve root, but there are no exiting nerve roots in the cervical region. Important to remember, C7T1 involves the C8 nerve root, and then from every level distal to that, the exiting nerve root exits below the corresponding pedicle. So T1 below T1 pedicle, and L1 below L1, or L1 nerve root below L1 pedicle, so on and so forth. This study I always deal with because we get a lot of questions about, well, this patient only has C6.
Hey, Wellington, sorry to bug you. I don't know if you guys are seeing it, but I'm not seeing your shared screen.
Oh, you're not?
Yeah, sorry, I just realized that.
No problem. Can anybody else see my screen?
Yeah, I'm able to see it.
Okay. Let's see here. Anybody else not seeing my screen?
Sorry, no, I just realized the gallery window was like maximized over it. Okay, I see it now.
Oh, got it. You got it? Okay. All right, cool. So we're on the Slipman study. This study I deal with, or I cite, I should say, because I often get questions about patients who present with a classic C6 radiculopathy, but they have a C6-7 disc herniation that should present with a C7 radiculopathy. The fact of the matter is that many patients with the same pathology or the same the same anatomy may have crossover in their innervation of dermatomes, and it happens very regularly. And this study indicates that because it was the first study to use nerve stimulation. It was prospective. It used a selective nerve root block to allow patients to feel what they should feel during the stimulation of a certain nerve root. And then the research group used a 793 body sector bitmap and categorized and defined where symptoms were after stimulation of a nerve root. So although a C6 radiculopathy classically will go down a C6 distribution down to the thumb, it doesn't always occur that way. And so this sector body bitmap allows us to look at how there's variation with the types of symptoms one may have with disc herniations. So to illustrate, it's certainly more common for C4 and C5 individuals to have only pain in the trapezial area and not travel all the way down to the hand, although you'll see a very light shade in the C6 distribution for C5. And then in C6 and C7, you can see the gray or the darker gray indicates a higher frequency. And so the more people than not will have a classic dermatomal distribution. But as the other gray colors indicate, there are many individuals that do not have the classic presentation of a dermatome. So just because somebody doesn't have the classic dermatome for the pathology that you would expect in MRI doesn't necessarily mean that that pathology is not causing that individual symptoms. So sometimes we'll get complete opposite pathology, whereas a left-sided disc herniation is obvious, and then somebody presents with right-sided symptoms. I believe that the crossover, from left to right is much more uncommon. So it's really the dermatomes on the same side that I believe to be quite common. So this study concluded that it's not uncommon for stimulation to provoke unexpected symptoms. There are normal variations likely excluded previous studies, and that you can have intrathecal root anastomoses. And then finally, patients may not be reliable in where they have pain. They may not characterize exactly where they have pain based upon their ability to feel it and that sort of thing. But that being said, C4, C5 typically proximal, C6 through C8 typically distal. But when you get into the C8 pathology, it's really anybody's ball game here. Like it really could present in a number of different ways. But the classic take-home point from this study, though, is that intrascapular pain can really present with any type of disc herniation. So you guys have seen the individuals in the clinic who have intrascapular pain, but no classic radicular pain down in extremity. Some surgeons will say that that's not related to radicular pain, but in my opinion, this study indicates that you certainly can have, or this could be a form of radiculopathy. A selective nerve root block is one where we just use anesthetic and it's just localized in the foramen of a particular nerve. And we typically use it to confirm etiology, pain and level. We use it as a diagnostic type of test. It can be therapeutic, but more or less diagnostic. I don't use these as classic as much as probably other surgeons, mainly because I believe that surgeons should be looking at the pathology of the MRI much more than relying on the subjective response to an anesthetic injection. But on occasion, if you truly are truly are confused, then this can be helpful. So intralaminar injections we use are not nerve root blocks. They're really administered for therapeutic benefit. Although I believe that if you're confused whether or not the symptoms are coming from the cervical spine versus the carpal tunnel, say, an epidural can be equally as effective in the diagnostic category. It just won't determine whether or not the patient is feeling it from C5, C6, or C7. Sarin and anesthetic is typically injected and typically safer than a selective nerve root block or a transforaminal injection, because these type of injections occur outside the canal where the vertebral artery lives. And so the vertebral artery can be at risk with an injection. This is the reason, this is the reason why we only administer anesthetic and not a particular steroid that can lead to a stroke after the injection. And again, yeah, to differentiate between the cervical and another body part, you may not need a more risky injection such as transforaminal. So myelopathy is different from radiculopathy. Here we're talking about a functional abnormality of the upper and lower extremities. Patients have myelopathy largely because of central stenosis. Here we see a normal spinal canal with a normal CSF ring around the spinal cord itself. And then here we see a grossly abnormal spinal canal with not only bony abnormalities, but also a congenital type of a narrowing of the canal as well. The surgical indications for radiculopathy typically are pain over 6 weeks, progression of symptoms, significant weakness, associated myelopathic changes, certainly, and then finally a deformity. Now, the weakness portion, you guys, I'm sorry, if this shows up on a test, certainly significant weakness is a indication for surgery whenever nerve root compression is present. But the relative weakness, in my opinion, is certainly important. I would say that 85% of our patients who present in clinic and have weakness typically have 4 out of 5 weakness. And although this certainly needs to be documented, more oftentimes than not, these patients will get better on their own. So that doesn't necessarily mean they have to have a surgery at that moment. On the other hand, if you got some individual who really is concerned about the weakness, even though it's mild, let's say they're a professional athlete, or let's say they are a very competitive recreational athlete, or let's just say they want to take care of the issue and aren't comfortable with the weakness, then we proceed with more invasive treatment. But I certainly would wait on weakness on 4 and above. I think folks with 3 weakness or lower is certainly a little more apt to talk them into surgery, but it depends on the patient themselves as well. So the way we treat an individual who's 59 with acute C7 radiculopathy with a mild amount of triceps weakness and 10 weeks of symptoms, this is going to be different than the same individual with the same disc herniation with the same neurologic exam. We know that folks with weakness certainly may have the clock be ticking at that time, so we offer them invasive treatment. But more, I would say more often for the general population, we can wait, and as long as their pain is well controlled and they are progressing by improving their strength and not decreasing it, then conservative care is reasonable. In terms of overlapping syndromes, cervical stenosis can confuse a diagnostician because there are other disorders that may mask it. So there's certainly the cervical disc herniation with the nerve root phenomenon. There's a thoracic outlet syndrome where the first rib can compress on the vasculature as well as the brachial plexus. Parsonage-Turner syndrome is a inflammation response from the AIN, which can present like a radicular type phenomenon. But typically these patients have a normal cervical MRI, and Parsonage-Turner patients are diagnosed through an EMG, an NCS test. Brachial plexopathy comes into play if somebody has trauma or somebody's found down and they have a radicular type phenomenon or a weakness with a normal MRI. A lot of these patients, when they come in, they already have imaging, so we're trying to find what's causing some of their deficits. But somebody who's either had trauma to their brachial plexus or a chronic compression phenomenon can present with acute sided weakness as well. Rotator cuff tear, hopefully most of us can determine this between a cervical stenosis, although there are some confounding patients as well, but most shoulder related in pathology will present with anterior shoulder pain, whereas most cervical pathology will present with posterior shoulder pain. And these are not 100% accurate. However, those are trends that we tend to see when folks have shoulder versus cervical. RSD really can present in any way. Patients will have just pain down the entire arm in a non-dermatomal distribution. This condition typically improves with a selective nerve root block, and these patients often can be treated chronically as such. So our years of experience with cervical discography indicate that patients can have intrascapular and neck pain from a number of different discs. Case in point, if you do discography at C2-3, this is the characteristic type of pain area that you'll stimulate. C3-4, a little bit lower than that, but in the axial region, or remains in the axial region. C4-5 now encompasses the intrascapular and posterior trapezial plane, whereas C5-6 and C6-7 marches down a little bit lower. You often have patients say, I have pain in the axilla, and point into their anterior aspect of the armpit. This is clearly different from an anterior shoulder pathology, and often can indicate that the C6 or the C7 nerve root is compressed. And some patients just present with that pain and not your classic radicular type phenomenon.
Hey, Wellington,
These
quick question: is that also what people refer to as like the cervical angina, or is that a little bit different? Because I've heard others say that's kind of a C6 nerve root, kind of an anterior chest pain rather than kind of like axilla pain.
Yeah, I would say the angina pain is different. You're right. The angina is more anterior chest, anterior left shoulder. What I'm referring to is some folks they'll grab their armpit, like the inside of their armpit, and it usually travels posteriorly. And the classic patients who have that have a C7 dermatomal distribution. So usually that's associated with a C7 radicular finding, but others folks will just point to their armpit and not have pain anywhere else. And I've seen C6-7 disc herniations cause that. But I think the cervical angina, that can be, you're right, that can be a number of different nerve roots, C6 being most common.
Got
it. Okay, in terms of testable material, I think this is certainly something I've taught for years now. So the difference between if you're confused between a cervical spine condition, a shoulder, elbow, hand condition, these are the tests that are specific for that particular area of pathology. Cervical spine, the Sperling sign will localize the cervical spine, hopefully nothing else. For the shoulder, we test impingement, empty can sign, for rotator cuff pathology, impingement pathology. In the elbow, if you have medial forearm if you lose medial forearm sensation, that implies that there is a brachial plexus or a cervical issue as opposed to the ulnar nerve, because as we all know, the ulnar nerve does not supply any sensation to the medial forearm. It actually supplies sensation just to the hand because it skips that area, and it's the medial antebrachial cutaneous nerve that supplies the medial forearm. So these are tests that we need to perform for all individuals where there could be overlapping conditions. Finally, the hand, and this is incorrect. I should change this. This should be the abductor pollicis brevis strength. That is the muscle that is most or mono-innervated by the median nerve, and is tested by asking the patient to flex and to pronate the thumb towards the opposite shoulder. And so if somebody is weak in that area, I'm more likely to diagnose carpal tunnel pathology rather than cervical. Okay, so let's move to a case here. This is a real life example, a 28-year-old female who fell while water skiing and complained of right-sided arm pain that radiated into the index and middle finger associated with paresthesias. And this is her exam. She's She's got a Sperling sign. She's got acute weakness that is more than your typical 4 out of 5 weakness. And she has this MRI that shows a quite large disc herniation at C6-7. And this disc herniation is actually in the foramen. You can see a portion of it is underneath the spinal cord or in front of the spinal cord, but most of it is in the foramen. So when we look at disc herniation, everyone who needs surgery is a candidate for a discectomy infusion and a arthroplasty, but not all individuals are candidates for a foraminotomy. But this patient is, because most of the disc is lateral to the spinal cord. If the disc, or most of the disc, were underneath or anterior to the spinal cord, then you aren't able to retrieve it or to take it out with a foraminotomy-like approach. Because the only accessible area from a foraminotomy is lateral to the cord. The spinal cord and the cervical spine is unlike the lumbar region, where we cannot retract medially. We cannot, or we don't want to move it. We don't want to do anything to the cord. But if the disc is far enough lateral, then we can typically fish it out with a hook without having to disrupt the spinal cord area. So important to review the borders of the cervical foraminum. Clearly the disc is anterior, because if you have a disc herniation, it'll go right into the foramen. And then we've got a superior and inferior pedicle that are the superior and inferior borders. So a C6-7 disc will have a border at C6 and then C7. And then finally, the superior articular facet posteriorly is the posterior border. So you cannot do a foraminotomy without removing the superior articular facet. This picture also indicates why some folks who have up-down stenosis, as opposed to anterior-posterior stenosis, will not improve from a foraminotomy. Because if you've lost the height of the foramen, let's say with a severely degenerated disc, and the nerve is being pinched in that way, it doesn't matter how much superior articular facet you take out, that patient will still have foraminal stenosis. So the typical sort of approach here is an anterior discectomy, and we've seen all seen that a number of times. But what we haven't seen a lot of is a posterior foraminotomy. And so this is a very sort of brief description of how we do it. When we do it posteriorly, we identify where the intralaminar V is, and then we take a point between that and the lateral edge of the facet. We divide that about 50%, and then those are our borders of stability, where we can remove as much bone medial to that, but nothing lateral to that. So what we're removing here is the inferior articular facet, which covers the superior articular facet. The patient's head is over here on the left, and the butt is on the right. And so by removing the inferior articular facet, we expose the superior articular facet, and that is the final layer that needs to be removed before we are able to get down to the foramen. And so most foraminotomies don't show this picture, but here we can see that we use a very small arthroscopic grabber. We're moving the nerve root over, which is right here, and that disc can pop out and be relieved, and the nerve root can be relieved. Again, this is not a very typical appearance of a foraminotomy, because typically this area is it's got a lot of blood in it. The exposure isn't very good. You're not sure if you're pulling on spinal cord versus nerve root, and can be quite painful to actually perform. But I think in the ideal situation, an individual who are performing motion sparing procedures and who has a disc that's accessible, such as this patient right here, you can see we left a little bit behind here centrally, which has to happen if we're doing the foraminotomy approach. But one can see that we took the disc out, the nerve is free, and the patient is going to be happy in the end. These are the kinds of discs that are not good foraminotomy candidates. The central disc that's calcified, even the posterolateral disc that's calcified is also not a good candidate, unless you're just looking to decompress and hope for the best. So CT scan is certainly considered before we do a foraminotomy. So the younger patient population will have a higher failure rate. I think the evidence is pretty clear about this. It doesn't mean that all young patients need to have a fusion, but the younger population needs to know that their chance of a revision with a discectomy and fusion versus a disc arthroplasty, that's a really, or that is a significant phenomenon that is can't be ignored. Okay, so disc arthroplasty isn't something we see often here, and it'll become apparent why. But it's also important to know that there are indications and certainly some ideal patients for this technology. It makes sense that motion is better than fusion. I would say that some patients' reported outcomes may be improved, kind of dissect the literature a bit here. Reoperations may be reduced with the current literature that we have over a 15-year period of time. Most patients' reoperations are not reduced, but then again, they could be reduced in 20, 25, 30 years. There are 3 different types of designs for disc arthroplasty. There are ones that have a fixed axis of motion, a variable axis of motion, and then there's variations with the type of design, including a ball and socket, ball and trough, and mobile core. Most devices now that are used have a coupled translation with rotation. So it's not just in one plane where you have the motion, but it actually translates as you rotate, which is more typical or more representative of what a native cervical disc behaves like in a biomechanical fashion. There are 7 cervical disc arthroplasty devices that are on the market. Again, we in our practice do like 1 or 2 a year, mainly because we as a group do not believe that there is a significant or revolutionary benefit when we use these devices compared to fusion. That being said, a fusion is not a perfect procedure. As we can see over a 5-year period of time, there's a slow decline in the outcomes after surgery. And so there certainly is an opportunity for improvement. We just haven't seen this improvement dramatically when it comes to a total disc arthroplasty device, especially in those patients with single level disease. Now, individuals with 2-level disease are a little bit different in my opinion. And this study, along with others, have shown that when you just compare 2-level patients with each other, that there could be a significant improvement in outcomes and reoperation rates at the 5-year period of time. And I believe this because it's not just this one study, but a multitude of studies that have shown this. Now, there are inherent biases with these studies that we won't go over, but and the choice to perform a reoperation is really the surgeons. So that there certainly could be a bias as to who gets offered a reoperation. However, in many cases, the numbers don't lie. And if the group that has a 2-disc arthroplasty has more improvement clinically and reoperation rate that is lower, then I don't think we can ignore it. But for a 1-level, most studies really show no difference. And so that's why I tell my patients as well. Okay, but there are times when ACDF fails us, even though ACDF is a very straightforward operation. I think it's a safe operation, a very quick recovery. There's certain patients that really don't necessarily do well, including multi-level disease. I think a 2- and 3-level disc fusion is different than a 1-level. We have plenty of young patients who develop adjacent segment degeneration within a 5-year period of time after an ACDF. One could argue whether or not the total disc arthroplasty could decrease that in that particular patient. But certainly most of us would agree that if that patient had a foraminotomy or was a good candidate for a foraminotomy, that their incidence of adjacent segment disease would be less. Skip pathology. This is a very difficult problem to treat with an ACDF because you're really faced with having to do a 3-level ACDF for this individual. There are some that would leave that 1 disc in between, but I am not in that camp. And I believe that if you do need to treat the 2 discs that are 1 disc apart, then this patient really needs a 3-level surgery. And a 3-level surgery is fraught with increased risks, complications, and operative time. ACDF also fails us when there are risks for pseudoarthrosis. 25% of the patients we see are smokers. We also have patients with or on immunosuppressive therapy. These individuals are greater risk for pseudoarthrosis and a poor outcome. To summarize the clinical studies, I would say that the arthroplasty success rate is better, if not just as good as ACDF. Outcomes out to 8 years. You'll find some that are better, others that are the same. The rate of adjacent segment degeneration is the same as ACDF, as defined, especially for one level. I think if you separate out the two levels, you may find a difference. And the rate of reoperation may be lower than ACDF, especially in two-level disease, but there are selection biases that we need to take into account. And the fact that we don't have data greater than 15 years, and many of our patients are in their 40s, so it's hard for us to say what the behavior of this arthroplasty would be 50 years from now. Conflicts of interest are always a topic. Certainly doesn't mean that industry-sponsored studies don't mean anything, but we have to take that into account when we interpret this. The wear rate phenomenon is one that's certainly on my mind. We've been burned by wear rates in the total joint literature and the total joint experience, and it's impossible for spine surgeons to ignore this. And so, not only the type of wear, whether it's from metal on poly, metal on metal, it's also the fact that we operate around the spinal cord and have neurologic elements to worry about, and how these wear particles behave compared to neurologic tissue really is unknown. So we don't know what it's like 40 years from now. We know that metal on metal leads to wear particles that are greater in number, and there could be a systemic effect leading to potential issues. We know that pseudotumor formation can also occur in total joint arthroplasty, so they've also been described in the cervical spine. If you review the literature with different devices, though, we know that inflammatory cells are frequently present. And we also know that some patients can have a hypersensitivity to metal. But, and so the conclusion is that cervical disc implants consistently are associated with metallic debris and inflammation. We just don't know the relative clinical sequelae from this pathologic fact. There's one patient that I had to revise who had a total disc arthroplasty 2 years prior. She ended up getting infected, again, 2 years out, which is unheard of. And I would have to imagine that if she had an ACDF, that this wouldn't necessarily have occurred. She had a neck procedure where it was a type of skin procedure, like an aesthetic one. And she had this like a week before she had the infection. So it's possible that the bacteria seeded that way. Okay, quick mention about myelopathy. So these are the symptoms of myelopathy that I don't need to go over with this group. The natural history of this phenomenon is that it's a stepwise decline. So patients typically do well over time, but they have this acute worsening that then leads them at a lower baseline. So if this is the pattern that you're hearing from patients clinically, then surgery is indicated sooner rather than later. If somebody has just been living at the same rate of dysfunction for years, 5-10 years, let's say, I'm certainly not talking that patient into an invasive operation if they don't wish to proceed with that. Once significant signs and symptoms are seen, the prognosis is poor. So somebody who presents with like the inability to walk, for example, from myelopathy has a much poor prognosis than some with milder symptoms. Improvement with non-operative treatment is rare, but we can always just watch them and make sure that their symptoms don't get worse. The common question that comes up is, what would you allow these individuals to do even if they were asymptomatic? I think for most activities, I allow individuals to do all that they want and don't restrict them. The one activity I have a conversation about is in depth is skiing and snowboarding. I think that that's a recreational activity that can present a lot of potential harm if somebody does have a head trauma, even in the setting of an asymptomatic cervically stenotic canal. So it doesn't mean I prevent them from doing it, but we have a long discussion regarding that particular activity. These are the physical exam findings that you guys all know. We've got the Hoffman's reflex, inverted radial reflex, the finger escape sign, Babinski. All of these should be tested. There may be a disconnect in terms of how we treat patients with big physical exam findings without symptoms. In my opinion, these exam findings are important, but somebody with just physical exam findings and no symptoms, in my opinion, does not warrant an operation. I still call them myelopathic because they have signs of myelopathy. But unless a patient is telling me that they are declining, I often, offer non-operative care for these individuals. And then we ask patients to open, close their hands as fast as they can. You can usually tell the ones who have fine motor coordination issues versus those who do not. Broad-based gait, tandem gait, and then finally symptoms with neck hyperextension. So the conversation I have with these folks are that they're either on the train that's leaving the station or they're sitting at the train station watching the train go by. If you have no symptoms, then you're just watching the train go by. You can wait for as long as you want to do anything about cervical stenosis, not really significant. But if you have even the mildest symptoms, then the train has left the station, so that train will either progress slowly or fast, depending on how quick you go, or how the pathology behaves. So why do we perform surgery? Well, we perform in a setting of a progressive neurologic condition in patients who have an inevitable decline in functional status. I would say that this is a very small percentage of the patients that we see with myelopathy. Those with more severe symptoms have a more unpredictable recovery. So we do tend to treat it early, but there's a balance because some people who have early and milder symptoms really don't want to have surgery, and we can certainly watch them. There are some positive predictors of the outcome from surgery, including younger age, larger transverse area of the cord, less severity of myelopathy, shorter duration of symptoms, and single level of involvement. And as we talked about, there is an increased risk of paraparesis with trauma with those with cervical stenosis. But as I tell every patient, that risk may go up by twofold or may go up 100%. But we're really talking about the difference between 0.5% and 1% as opposed to anything else. So not necessarily the reason that we would do surgery. Okay, the goal is a surgical treatment to maintain long-term spinal cord function first, minimize complications second, and then to improve clinical outcomes third, short-term and long-term. The anterior approach involves removing the shoe, or I'm sorry, the pebble in the shoe in that analogy where you have a pebble in the shoe, you want to actually remove it and go directly after it. It's a more complete decompression. It's an anterior compression most commonly that we see in spondylotic myelopathy. It's ideal in kyphotic spines because with intraoperative positioning and anterior column support, we can correct this. And we also remove a pain generator. So assuming that somebody may have neck pain from a degenerated disc, we can remove that, stabilize that, and also have the chance to reduce long-term pain. But on the flip side, the advantages are decreased estimated blood loss, decreased wound complications. There's some pitfalls of laminectomy that we avoid, and most surgeons are very familiar with this approach and can do it very quickly. That being said, there are complications from this procedure, and the rate of complications when we talk about multi-level issues, including graft complications, instrumentation failure, surgical site complications, that certainly is higher anteriorly than it is posteriorly for multi-level problem. Fusion disease, if you compare it to somebody like a laminoplasty, there's definitely an increased rate of adjacent segment degeneration. And range of motion, you certainly lose more when you compare it to a laminoplasty, which is a motion-sparing procedure. Laminoplasty patients do lose motion, but not as much as if you were to fuse the segment entirely. The posterior approach is advantageous because it avoids the anterior neck complications that we talked about. A lot of these patients don't need bracing, especially if they have a laminoplasty. But there are disadvantages with going posterior. They're more inconsistent axial pain relief, posterior muscle disruption, which leads to an increased recovery time, And it's more of an indirect decompression. You're kind of leaving everything you see anteriorly, and that could, in theory, lead to an issue down the road. Here in Northwestern, we've defined congenital cervical stenosis as an individual less than 50 years of age with a mid-sagittal canal diameter of less than 10 millimeters at multiple levels. And we measure this at the pedicle level. And it's important to point this out because when we say somebody has congenital cervical stenosis, it does imply that their deformity or their pathology is in a certain location and could lead to the need for treatment. We found that congenital cervical stenosis patients have smaller lateral mass, flatter angles. We call this the lamina disc angle, which is right here, the the LDA. And then this flatter sort of surface makes a flatter canal that makes the stenosis much more common. So this is what we typically see in a normal canal, and we've got these normal angles. And somebody with congenital stenosis, again, one without significant degenerative pathology. These are younger patients, and these are measured at the pedicle level. You can see how much flatter the lamina is compared to the disc, and that leads to compression of that spinal cord. So this triangle model indicates that this is a posterior-based anomaly, which makes me think about treating these patients posteriorly more often than not. Now, not everybody needs a decompression at a level that they're congenitally stenotic in. But if the goal is to treat congenital stenosis at multiple levels, then, and because it's a posterior-based anomaly, I believe that a posterior approach makes more sense because that's where the pathology is. So here's an example. This is a 35-year-old individual who's a lead singer in a rock band who complained of 2 years myelopathy. And these musicians, they will really know when they have myelopathy because they have difficulties with fine motor manipulations. This patient also had left arm radiculopathy and neck pain, and had physical exam findings to boot. And so he's a bit uncommon in the sense that he's got cervical stenosis lower than what we would typically see. This patient does have congenital stenosis, but also has spondylotic changes at C5-6, C6-7, and C7-T1. And you can see from the axials that this leads not only to central stenosis, but also right-sided foraminal stenosis leading to radicular pain. Not only that, but if you were to look at the sagittal, which I did in this individual, even though the axials didn't go all the way down, you can tell that at T1, T2, there is also pathology on the right side. And sure enough, when we see or when we performed another thoracic MRI, there was pathology in the disc in that area. So this can't be ignored. So, a typical approach to something like this would be anterior versus posterior versus anterior posterior. And most of them would involve fusions. But I think that fusing a lead singer of a rock band likely will affect this individual's to perform on stage. So we actually ended up doing a laminoplasty, and you're not going to find a lot of people who do a laminoplasty in the thoracic region. But having done it, I don't think it's as big of a deal as one would think. It does cross a cervical thoracic junction. We don't have a lot of data regarding that. But this is a motion sparing procedure. It's an indirect decompression. It does not involve a extensive anterior, posterior, or corrective surgery that may put him out of his profession. So this individual actually ended up doing very well and turned his job and had a very quick recovery. So motion sparing, even in the cervical thoracic junction, is certainly possible. For some patients who we don't know how to treat, whether to go to anterior or posterior, and we did this study a few years ago that I think is a really good way to address that. We looked at 180 patients, MRIs. So most often you'll have patients who present with an MRI and an X-ray. The X-ray isn't very good to determine whether or not you can access the C7-T1 disc because, first of all, the C7-T1 disc isn't very commonly seen on a sagittal view. And then secondly, the angle in which the clavicle is not very helpful. So we went through this novel algorithm using the scout film of a T2 MRI and determined that this was the most successful way to determine what the lowest level of disc was accessible from the anterior cervical region. So this is a great example of an MRI that does not have a saturation band where you can see the suprasternal notch and you can see where the C7D1 disc is. But this is how most MRIs present. They have this spatial saturation band. So it's impossible to know where the clavicle is. So using a scout film where there is no saturation band, one can easily identify where that suprasternal notch is and then calculate whether you can access it through a T1, T2, or in this case, even T2, T3. And so the conclusion of this study is that more people than you think can be accessible at C7T1 and even at T1, T2. So patients with this pathology at least deserve a look. And in my opinion, the surgery difficulty is not that great when it comes to this level compared to another level. It's just a little bit deeper. Okay, so this is an individual who has a 2-level pathology, spondylotic, is myelopathic, and has moderate central cervical stenosis. So 1 and 2 level problems without a congenital issue with anterior pathology. These patients are best treated anteriorly. And so it comes down to the pebble in the shoe analogy. If you have a pebble in the shoe, you can either remove that shoe or remove that pebble directly, or you can loosen the laces around the shoe to accommodate for it. So removing this shoe then involves an ACDF. I don't think this patient is a good candidate for a disc arthroplasty because the amount of arthritis, especially at C4-5, is too great. Those patients with really severe arthritis or severe spondylosis, they will end up fusing anyway if you do a total disc arthroplasty. So it's much better to just proceed with a fusion from the get-go. This is a different case, 53-year-old individual with a much more significant history of myelopathy. She can't walk. She's wheelchair dependent. She had left arm weakness, bowel and bladder incontinence, loss of rectal tone. She's morbidly obese, and she's got this really awful looking cervical spine, multi-level spondylosis. In this situation, if we were to go anterior, who knows how long this would take, because this is probably a 3-level corpectomy. It probably would involve posterior fixation as well, because you're not going to do a 3-level corpectomy of a standalone. And the risk of having this osteophyte sort of work into the dura, getting a durotomy is very high. So the risk of complication will be very, very high. I should say the risk of surgery in general is very high, but it's reduced somewhat if you can do it just a localizing approach. So here, we don't want to take the pebble out of the shoe. We just want to loosen the laces and give the spinal canal more room. And so cervical laminoplasty is a very good option for this. What we need to do is identify the border between the lamina and the lateral mass, and then make osteotomies on both sides. On one side, we do a hinge osteotomy, only cut through half of it. And the other side, we cut all the way. And so we can open up the canal like a door, and this is called an open door technique. And then in order to keep the bones open, we put a small plate on with a few screws. We're counting on this hinge side of the bone to heal, and then that will provide the eventual stability and thereby obviating the need for the plates long term. So this individual has preoperatively severe cervical stenosis and postoperatively a much wider canal. And you can see that her spondylosis it's not really OPLL what we're seeing here, but we're seeing an ossification of her spondylotic fragments from C4 down to C6. So this has an equal possibility of getting into the dura and that sort of thing, in my opinion. All right, so that's that's all I have. Why don't I end the show here? Let's open it up for questions or discussion points, or whatever you guys want.
Dr. Sue.
Hey, Manish.
Hey, thanks for a great talk. Earlier, you were talking about skip pathology.
Yes.
I was wondering, is there any circumstance, obviously we were talking about and sort of not leaving the segment in between alone. Is there any circumstance where you'd address one level and not the other, and therefore just like a single level ACDF?
Yeah, absolutely. you'd only do that though if the symptoms warrant it. So, what do I mean by that? Let me bring this patient up here. Can you see this this MRI? Okay, so we've got a C4-5 and a C6-7 disc herniation, and this patient has right-sided radiculopathy. Unfortunately, I can't treat this patient, in my opinion, by leaving one of these. Even, let's say if somebody had a C6-7 classic radiculopathy, but has a C4-5 posterior ossified complex like this individual does, I cannot, in good faith, just do C6-7 unless C4-5 looked better than this. So it's because of the potential for cross innervation and crossover in the nerve roots that if you were to leave this, I think you're just leaving this the possibility that the patient will continue to have pain despite having a successful surgery. What we often may see is somebody with central stenosis, but no foraminal stenosis, and somebody with disc herniation, a couple levels below, and a classic radicular pattern of pain. If you do have that, then that individual can be treated with a single level, because you're not necessarily treating that individual for myelopathy, because that patient doesn't have myelopathy. That patient just has a single level radic. And if you just treat that level, as long as that patient doesn't have any, myelopathic signs, then that patient may do okay. But in something like this, though, when you got bilateral foraminal stenosis, right, greater than left, and then right-sided symptoms, you gotta know what you're treating. And if you're treating radiculopathy with this pathology, then you're basically succumb to a 3-level operation. One would argue, well, why can't you do a total disc arthroplasty at those 2 levels and then save the level in between? In my opinion, if the evidence was surely that clear that if you were to do a total disc arthroplasty, that you would reduce the adjacent segment degeneration rate significantly, then I would certainly offer that to this patient. But in my opinion, that really isn't the case. And so it's either 3-level or none for this individual.
That makes sense. Thanks, Dr. Su.
Sure. Anybody else?
Hey, Wellington, what about people that are starting to do more like 3 levels or 4 levels of total disc arthroplasty? What are your thoughts on that? And then the other thing would be, is there like a certain kind of morphologic criteria on MRI, like a cutoff, like how much spondylosis is too much before they're not a candidate for arthroplasty?
Yeah, good questions. I'll take the last one first. So, amount of spondylosis. The folks in the ID trial will say that they will not operate on somebody with more than 50% disc height loss compared to a normal disc. I can tell you that those guys are probably not telling the truth, because they do. They do operate on patients with, only 10% disc left, 90% arthritis. Some folks even do it on bone, and they enroll them in the trial because I've seen it. So that's a very aggressive way of treating disc arthroplasty. And these surgeons, and this is where the selection bias comes in, you have to take that into account. These surgeons have an incentive to enroll patients and have an incentive for the device to be studied fully. So they may, massage those indications to a bit. Most will admit that those patients will just end up fusing, but they'll also admit that those patients end up doing okay, because we know that fusions actually do all right in the long term. So that's not necessarily a bad thing. It's just that we can't really tell if it's the disc arthroplasty technology that is making them better as opposed to the fusion. Now, for me, anybody with significant, I would say more than 25% disc height loss, in my opinion, is not a good candidate for a disc arthroplasty, because the reason we're doing the disc arthroplasty is to preserve motion. And it's only those individuals with very mild disc height loss are the ones who may even have the opportunity to retain motion. And that's how we'll truly know if those individuals will do better in the future. So my indications, Really, the only ones I'm doing it now are folks with a normal appearing disc with a soft disc herniation. And these are patients who are asking for the technology. We don't get a lot of those around here. It's not my role to sort of talk somebody into it, but when I present the sort of uncertainties on both sides, most individuals are saying no, and then no to the disc arthroplasty, and then just doing the fusion. Your first question about the 3 and 4 level disc arthroplasties, yeah, that's a bit crazy, simply because it's not studied very well. And again, when we're talking about wear rates, 1 and 2 level, if you're worried about a 1 and 2 level, man, I mean, think about the amount of wear you're going to get 3 and 4 level. That will just may compound the issue. And if those wear rates disintegrate the bone or lead to osteolysis or whatever, you got a real problem in that area. So I certainly think that more than 2 levels, I'd call that surgeon a maverick for sure.
Right. Yeah, that's what it seems like. And I think you make a good point about the amount of disc height loss needed. Because one thing that always confused me with these studies and arthroplasty in general, when they reported, some of these studies report 50 to 80% like HO rates, like kind of auto fusion rates. And so maybe that has to do with the actual patient selection. And, like what I found a hard time believing was that the patient reported outcomes, were better at 2 years, but then why are the radiographic findings, not as good, right? Like if it's auto fusing across a level, then are they still really maintaining the motion? And is that the reason for improved outcomes? That's what I found confusing about these studies.
Yeah, it's a good point that we don't really know, especially when 30% of them fused. And most of these studies will freely admit it, that after 2 years, 30% of their patients achieve a fusion, even though the intent was a disc arthroplasty. But it depends on how you look at it. The investigators in the study would just be like, well, the patient's doing okay, so nobody really cares. But from a scientific perspective, it really doesn't answer the question. And the question is disc arthroplasty or motion sparing technology, is it actually better for patients who are a certain age group with a certain amount of mild spondylosis, and can they get back to activities quicker and have a quicker recovery? Yeah, I mean, for everyone in the call, I don't think anybody at our institution is fully convinced of that. But as opposed to lumbar disc arthroplasty, which really nobody would do, I would say, you got maybe 1 or 2 surgeons in Chicago that would do it for the lumbar spine. In the cervical spine, doing this procedure is really, I think, totally indicated in the right patient. And so we look at that technology a little bit differently than lumbar.
Cool, thanks.
Yeah. Anybody else? Peanut gallery. All right, guys, we're 5:31 on the spot here. And let's end this. I think our next talk is 3 weeks from now. I think this is the last one before we go to winter break. So if I don't see all of you guys before break, have a great holiday, and we'll reconvene after that.
Thanks a lot, Dr. Sue.
Have a
Bye,
good one.
guys.